Going to study another important topic, which is renal neoplasms. They can be benign, renal papillary adenoma, angiomyolipoma, and oncocytoma. These are all benign, and they can be malignant, which is renal cell carcinoma and its subtypes, which is the most important entity for you, and urothelial carcinoma of renal pelvis, and there are other XP11 translocation and Bellini duct carcinoma. There are other, but RCC is the most important subtype that you should, and its subtype is something that you should know. Now coming to renal papillary adenoma, it's a benign tumor, small tumor. So the size is very important, less than 0.5 centimeter, and it originates from renal tubular epithelium. Anytime there is a tumor, whether in whatever organ of the body, the origin of that tumor is very important, because it might have originated in the organ that it is in, or it might have metastasized. So the origin of the tumor is very important. Renal tubular epithelium, it is mostly papillary, that's why it's called papillary. Morphologically and gross, it is less than 0.5 centimeter in diameter, and it is in the cortex. It is pale yellow, discrete, well circumscribed nodule. Microscopically, it has papillomatous structure, which are papillae are basically finger-like projections, and in this one they are complexly branching. So that means this one is branching further. So these are called fronds. So it says complex branching papillomatous structure with numerous complex fronds. So papillary is the most common pattern seen, that's why it's called papillary adenoma, but it can also form tubules, glands, cords, and sheets. So whenever there is a tumor, I'm just telling you otherwise, wherever the tumor is in the body, microscopically, how do you define it? How are we saying that this is this? How are we reporting whenever an organ with a tumor has come to us? There are two things to keep in mind. One is the architecture. No matter where is this tumor, no matter what organ, no matter what type, no matter size, whatever, you always have to, on microscopy, one thing that you focus on is the architecture. The second thing that you focus on is the individual cytology of the tumor cells. So architecture is basically how is the tissue organized. So this we see on histology. The first thing whenever you see on histology is the architecture. Like what is the organization? For example, this one has mostly papillary organization, but it can also have tubules, it can form glands, it can form cords, or it can form a proper sheet. Sheet means basically no pattern, just a plain एक लाइन में सब, मतलब एक शीट की तरह फैले हुए हैं, कर्टन बना हुआ है बस, ठीक है. So this is architecture. How is, now we have to also talk about the individual cell. The individual cells are cuboidal to polygonal. They're regular, small, central nuclei. Scanty cytoplasm, no atypia. The size of the tumor is used as a prognostic feature with a cutoff of 3 centimeter, because the metastasized, to differentiate it from the ones that have metastasized and from the ones which do not. Now angiomyolipoma, it's a benign neoplasm. So OMA we know, na? Whenever there is an OMA, we know it is benign neoplasm, if you remember your neoplasia chapter. So there are three components: angio, vessel, blood vessel; myo, muscle; lipo is fat. So there are three components: vessels, smooth muscles, and fat. The origin is perivascular epithelioid cells. So where this is a vessel, if you consider this is how a vessel is seen on histology, it's round, and it usually has these small, so pink color, I'm trying to draw it, like if you have a, this is a vessel you have, then you will have these epithelioid cells. So these are perivascular epithelioid cells. That's where this tumor is originating from. It has three components: angio, myo, lipoma. It is seen, so its main association is with tuberous sclerosis. So now what is tuberous sclerosis? It's a tumor syndrome in a way, but so what is happening is there is a loss of function mutation of there are two tumor suppressor genes, that is TSC1, TSC2. These are lost in tuberous sclerosis. So now it will have multiple lesions. So it has cortical lesions, brain cortex lesions, skin abnormalities, and benign tumors like heart and like this kidney, right? So kidney as well as heart and brain. Some cortical features, lesions in brain. These lesions will cause epilepsy and mental retardation, skin abnormalities, and unusual benign tumors. Now coming to oncocytoma. This is out of these three, this is the most important for you guys. So this is again benign OMA. Origin is the intercalated cells of collecting duct. Chromophobe RCC. So when we discuss RCC, I'll tell you about this entity called chromophobe RCC that also has the same origin. And sometimes histologically, morphologically, you cannot tell between these two, although that is a malignant tumor. So now coming to 10% of, this is 10% of all the renal neoplasms, benign or malignant overall. And it has this characteristic, so this is something you have to remember for lifetime. This is characteristic loss of chromosome 1 and Y. This is very, very characteristic for it. It will a PG question also, and it's an important one, associated with loss of chromosome 1 and Y. Another thing that is very important is whenever we use the word oncocyte, no matter wherever the organ, whenever there is this word called oncocyte, that means abundant mitochondria, which give the, on gross, the tumor becomes tan color because of mitochondria, and on histology they become finely granular, they have finely granular eosinophilic cytoplasm. Now what do we mean by this term finely granular eosinophilic cytoplasm? If you look at this picture over here, eosinophil mean we are using H, histope we are using H and E stain, which is called hematoxylin and eosin. Eosin is red colored or pink colored, and hematoxylin is blue colored. So hematoxylin is staining your nuclei. If you see, the nuclei are blue, and eosin is staining your cytoplasm. That's why they are pink. So here the cytoplasm becomes eosinophilic and it is finely granular. It is finely granular. You can't appreciate it on this one, but just remember, because of mitochondria, there is wherever you use the term oncocytoma, so that means this entity has abundant mitochondria, because of which on gross the color becomes tan, and on histology you see abundant eosinophilic cytoplasm. Because if you see these cells, these are big cells. They have abundant eosinophilic cytoplasm. You see these cells have so much eosinophilic cytoplasm. This pink cytoplasm. So much cytoplasm is there. And another important feature for this one is a central scar, a central stellate scar, which you can see on USG or MRI. So the three important points for this are So the three important points that you have to remember for this is loss of chromosome 1 and Y, abundant mitochondria, and central stellate scar. Now coming to the major entity that is very, very important for you guys is the RCC, renal cell carcinoma. Short form is RCC. So whenever I'll be using the short form RCC, you naturally understand it as it is renal cell carcinoma. The origin is renal tubular epithelium, and they usually arise in the cortex, because we know tubules are usually in the cortex. This is most common neoplasm, malignant neoplasm, most common malignant. So that's a very hefty number, 80 to 85%. So of all the primary cancers that occur in kidney, we are not talking about metastatic, right? Whenever we use the word primary, that means its own origin. It's not metastatic. So all the primary cancers that have occurred in kidney, so 80 to 85% of them are RCC only. 2% of all cancers in adults. It usually occurs in the older males, 6 to 7 decade, more common in males. And the risk factors are very important for this. Smoking, very high association with smoking, and in some females, obesity, hypertension, and unopposed estrogen, and exposure to asbestos, petroleum products, and heavy metals. If you remove hypertension, obesity, and unopposed estrogen and petroleum products, it's almost the similar risk factor as lung cancer. And another specific for kidney specific, some risk factors are end stage renal disease, chronic kidney disease, acquired polycystic kidney disease, and tuberous sclerosis. Now there are some syndromic association which these RCC have, because we will discuss the types of RCC. So first of all is the von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome, VHL gene is mutated in this. It is present on chromosome, VHL gene which is present on chromosome number 3p25, but you have to just remember 3p25 is the specific locus of which is mutated, but you have to remember chromosome 3. It has multiple renal cysts, bilateral, often multiple renal cell carcinomas, and both sporadic and familial RCCs can occur. So whenever patient has von Hippel-Lindau syndrome, it's not just that it will only have familial RCC because the gene is mutated. It can also have sporadic RCCs. Second is HLRCC, hereditary leiomyomatosis, नाम में है, and RCC syndrome. The word syndrome has to be added. So hereditary leiomyomatosis and renal cell carcinoma syndrome, again AD, autosomal dominant. This is FH gene mutation, fumarate hydrated gene is mutated, and it has, like in the name it said, cutaneous and uterine leiomyoma occurs, and aggressive type of papillary carcinoma, papillary renal carcinoma. Okay. Now coming to the third, which is hereditary papillary carcinoma, autosomal dominant, bilateral papillary tumors. Please forget this one. Bilateral papillary tumors, and the mutation is in the MET proto-oncogene. And then is the Bird-Hogg-Dube syndrome, again autosomal dominant, BHD gene mutation, and skin, pulmonary and renal tumors. There are some complicated names given in the book. You do not have to remember. Just remember these syndromic associations, which is one is the von Hippel-Lindau syndrome. Second is the HLRCC, नाम में है hereditary leiomyomatosis and renal cell carcinoma syndrome, hereditary papillary carcinoma, and Bird-Hogg-Dube syndrome. These are syndromic association with various RCCs. Now, this is some genetic mutations we'll discuss when we discuss the entities. Okay, let's discuss the entities. So overall, clinical, no matter what type of RCC it is, so it is characteristic triad of symptoms is present, which is painless hematuria. It is the most frequent presentation. More than 50% of patients will present with painless hematuria. That is, a patient will come and he'll say, I am having blood in my urine, but I do not have any pain while urinating. So sometimes this can be microscopic hematuria or macroscopic hematuria. So macroscopic hematuria is basically the patient can see that there is blood in the urine. Microscopic hematuria is only RBCs are only seen under the microscope. Okay, so that's the difference between microscopic and macroscopic. But painless hematuria, just remember this triad. You just have to remember triad, nothing else. I'm telling you, if I'm telling you extra points that are for you to correlate and sort of remember stuff, but you whatever I've written, that is all you have to remember. I've tried to make it very short so that you can remember points. Okay, so what is the classic triad? The classic triad is painless hematuria, palpable abdominal mass, and dull flank pain. Because as the tumor is increasing, it will start causing pain, because it's we know where the location of the kidney is, right? So it will start causing pain, painless hematuria, a palpable abdominal mass, and dull flank pain. Extra renal effects like fever and polycythemia can occur, but they are non-specific symptoms. And another important point here is that these patients will have paraneoplastic syndromes as well. So if you remember your list of paraneoplastic syndromes and why you have to, whenever, there can be a short note on just paraneoplastic syndrome also, by the way. So if you remember your list of what paraneoplastic syndrome is occurring, the cause of that paraneoplastic syndrome, and the entity, diseases, that is the tumors in which that paraneoplastic syndrome will occur. Hypercalcemia, hypertension, Cushing syndrome, feminization or masculinization, depending on the gender, and sometimes metastasis also can happen. So kidney is metastasizing into lungs or bone. Now classification, we'll come to the genetic locus. We will discuss this picture that was given in your Robbins. But first we'll discuss the classification of RCC. They are classified on the basis of morphology and growth patterns. So first is clear cell carcinoma. If it indicates, if it gives any indication, it is clear cell. This is the most important entity that you guys have to remember. We also have a papillary renal carcinoma and chromophobe RCC. Remember this whole classification: clear cell carcinoma, papillary renal cell carcinoma, and chromophobe renal carcinoma. Okay, just remember these entities. They are very important for you. Okay, now coming to clear cell RCC, it is the most common type. 70 to 80% of renal cell carcinoma. The exams that you guys just gave, I think pre-prop exam, we had a slide of clear cell carcinoma as a spotter also. So this will be given to you either as a spotter or in the practical exam when you're giving like the histo slides. So this will be definitely there, clear cell carcinoma. We'll see how it looks. So most common type. So that's why you have to remember it's you have to read it also, right? So most common type out of all the RCCs, 70 to 80% of renal cell cancers are clear cell. The origin is very important, proximal tubular epithelium. So the name is derived from the fact because it has clear or granular cytoplasm, most commonly clear, but it can have clear or granular cytoplasm depending on the lipid or glycogen content. If you remember adenocarcinoma, gastric adenocarcinoma, that was the first video that I ever uploaded. on that, if you remember, those cells had signet ring morphology. If you remember, the gross was leather bottle appearance, but on my microscopy we had clear cells and the nuclei was pushed, and I told you that because mucin is pushing it to the periphery. So again, that cell had almost become clear, but because of that, and it was pushing the nuclei to the periphery, so the stain is not picked up. Otherwise the cell would have to be pink. The stain is not picked up, so that's why those are clear, and the signet ring morphology that we were talking. So similarly here we do not have signet ring morphology. These are clear cells. There will be a central nuclei, but these are, I just want you to know, okay, I just want you to remember, they'll ask you, why are these cells clear cells? Why are they called clear cells? Because the cells are clear. Why the cells are clear is because of the presence of glycogen or lipids. 90% of the times these tumors are sporadic, but can be familial also. And classic association is von Hippel-Lindau disease. Von Hippel-Lindau syndrome, again we already discussed, it is an autosomal disorder, mutation of the VHL gene on 3p chromosome, predisposition to many neoplasms like hemangioblastomas of the cerebellum and retina, bilateral renal cyst, bilateral often multiple clear cell carcinomas. Now, why VHL gene mutation is so important? Okay, first let's come to this. Okay, this picture, this is given in your book. So when you are discussing papillary renal carcinomas, they can also be sporadic or hereditary. Your papillary renal carcinoma can be sporadic or hereditary. The sporadic will have a different mutation, which is trisomy of 717 loss of Y, mutated or activated MET, and hereditary will have only trisomy 7, which is mutated or activated MET. So the mutation, the gene is same only, it's MET. The gene is same, it's MET, but here there are 3 translocations different, and here the translocations are different. Trisomy is 7. Now on this side, if this is your clear cell RCC, again it can be sporadic, it can be hereditary as well. Here the deletions are on chromosome 3, and all of that is because of VHL. So here the mutation is VHL, and here it is MET. Just remember that, okay? That is, both of these tumors, both clear cell and papillary, can be either sporadic or hereditary, your familial. Now why VHL gene is so important? Now normal VHL gene causes the degrade. Normally when your VHL gene is present, it is causing your degradation of hypoxia induced factors, which are called HIFs. Whenever your mutated gene is present in the syndrome, HIFs are stabilized, they are not degraded anymore. Now what are HIFs are promoting carcinogenesis, because they promote 2 factors, which is VGF and your insulin growth factor. So HIFs are promoting 2 factors, which is VGF, which is, if you remember, vascular endothelial growth factor, it promotes angiogenesis, and IGF, which promotes cell growth. So both these factors are promoted by both these factors are stimulated by HIFs, and hence carcinogenesis is promoted. So normally this is inhibited by normal VHL gene, but if it is mutated or if it's absent, HIFs will be not degraded, and hence they will promote carcinogenesis. Now on gross, clear cell carcinomas are usually solitary, unilateral. We'll see how they look. On cut section, bright yellow to grey white spherical masses. Now why yellow? Of variable size, which distort the renal outline. Yellow because of prominent lipid accumulation in neoplastic cells. There are areas of, all these points are important. This point is very, this point solitary and unilateral. How do they look on cut section? Yellow, grey, well, bright yellow of spherical masses of variable size. They distort the renal outline. Yellow color because of lipid accumulation. Areas of necrosis or hemorrhage. Well defined tumors, and they are confined within the capsule only. Renal vein invasion is common, so much so that it can go through the IVC, through IVC into heart as well. Now on histomorphology, how do we see them? The tumor cells have rounded or polygonal shape. Round or polygonal shape, abundant clear or granular cytoplasm, which contains glycogen and lipids, delicate branchy vascular, cystic or solid areas may be seen. Most tumors are well differentiated, but they can be sometimes nuclear atypia with bizarre nuclear John cells. So the points that you have to remember here is, they have rounded or polygonal shape, abundant clear granular cytoplasm because of glycogen and lipids, and delicate branching vasculature. So these 3 is important points you remember. So if you see here, these pictures are not from your book, but your book also have a good picture. Robbins has a good picture, but this is, see, again a well circumscribed. You see this yellow lesion. This, if you see kidney, this is kidney, right? You can differentiate that this is, you can tell this is kidney, and this is the tumor we have. It is well circumscribed, it is yellow, and it is spheroidal. Why it is yellow? Because of lipid. And even though it's a cancer, it's well circumscribed. Large tumor shows typical variation of color. So again, what happens is sometimes it grows in weird area. This is cystic. These empty cavities wherever you see fluid like, that is cystic areas, and then we have these red, we have hemorrhagic areas as well. So hemorrhage and cystic areas are very common. Now this is a picture I've taken from your Robbins only, and this will be a spotter in your exam 1000%. This was in this time also. This was a spotter, and there is a high chance that somebody, it might not be a spotter, it might be given to you as a slide when you get those 4 histo slides. Now it might be as that also. So what do you see? Do you see glomeruli? Do you see these renal, sorry, not glomeruli, do you see these renal tubules? These are not glomeruli, these are renal tubules. And if you see, they have clear cytoplasm, they have clear prominent nuclei is also seen. I've zoomed in the picture, you can see prominent nuclei because this is a malignant tumor after all. And you can see these clear cells, the tubules are completely filled with these neoplastic cells. They have clear cells, they have the cytoplasm is clear because of accumulation of lipid or glycogen. And you see a tumor, and you see a prominent nuclei as well as in some cases you can say nuclei. This, please try to remember this slide because there's a high chance you can get it. Papillary renal cell carcinomas, 10 to 15% of all renal, so it is the second most common subtype of RCC. So name is papillary growth pattern, we talked about this. Papillary is like a thumb like growth, right? And it is multifocal, bilateral, appears as early stage tumor. Again we talked, right, it has both familiar forms and sporadic, like in that picture. Sporadic is 7-17-5 loss and familial is 7, and it has met proto-oncogene which is located in chromosome 7q. So wherever 7 is gone, so met proto-oncogene will be activated and cause tumors, cause cancer. So this is a papillary carcinoma. It has a lot of necrosis and hemorrhage. I just wanted you to see it. So the origin is said to be from distal convoluted tubules. Again, it is bilateral, multifocal, necrosis, hemorrhage. How are the cells? They have cuboidal or low. So again, one point you can add here is when you're just describing the morphology, papillary architecture. Like I told you, right, whenever you're describing on microscopy, whenever you're describing a tumor, you have to, on histology, you have to talk about architecture, and you have to talk about the individual cell morphology, which is cytology. Cyto is for cell. Architecture, that is how are the cells organized, what is the pattern in which they are present. So here we have papillary architecture. So here also you can, which we have I've mentioned in the previous slide, but you can mention here also on histology. You'll see the papillary architecture, which I'll show you. Necrosis and hemorrhage. So now what is the cytology? Cuboidal or low communal cells, they are arranged in papillary. Okay, it is, sorry, I didn't see it. It is written papillary formations. So we have established the architecture, we have established the cytology. Interstitial foam cells are present in the papillary core, that is the core of the papilla. This is the core. It is not important at your level, but just saying, whenever we have papillae, there is something called as true papillae or false papillae. If in the center there is a core, the core is usually fibrovascular, that is the blood vessels and fibers are present, that is called true papillae. But if it's a papillae which does not have this core, it's called a false papillae or pseudo papillae, and this is true papillae because it is a core. Smoma bodies, anytime there is a papillary neoplasm, you always suspect smoma bodies, no matter what part of the body. So papillary neoplasm usually have smoma bodies. Scanty stroma is there, but it is highly vascularized. Again, now see this picture. If you see this is all RBCs. This is red radias that you see. That means the tumor is highly vascularized. These are papillae. So these are papillae like this. The tumors was like this. May or may not be seen on gross like that, because these are not that long usually. This has been cut like this. So this has been the cut. So if you cut something like that, it will be goal, because these are thumb like projections. Imagine having a try to have 3D imagination. So if these are thumb-like projections rising from the surface of the kidney, and you cut them in half, you give a section, and then it will be circles. That's why we have these circles, right? So these are all papillae. They have low cuboidal to columnar cells. The architecture is more important here, that they are papillae. Chromophobe RCC, it is 5% of renal cell carcinomas. Among the three subtypes, the three important subtypes, which is clear cell, papillary, and chromophobe, chromophobe is the least common. It is composed of cells with prominent cell membrane, pale eosinophilic cytoplasm, and halo around the nucleus. This is very important. This is a halo. The origin is integrated cells. If you remember, I told you oncocytoma also has a similar tumor, and they have eosinophilic cytoplasm. So these are difficult to differentiate on sometimes histology. There is extreme hypopolydy, and there is these have excellent prognosis. Chromophobe morphology. So these are tan brown tumors. If you see, this is the tumor. This is tan brown. So they are made of pale eosinophilic cells arranged within. This is arranged in solid sheets. So pattern here is sheets, solid sheet. This is the pattern, the architectural pattern that I was mentioning earlier. The cell cytology is that they are pale eosinophilic, and they have all these cells. If you look at these cells carefully, if you see the cells, all of these cells have a pale halo around them. You can see a halo around them. So this is chromophobe RCC. The concentration of the largest cells is around the blood vessels. Now there are few minor entities, small entities that are mentioned in your book, so I'm talking about them. XP11 translocation, which is seen in young patients. The translocation of TFE3 gene, which is present on chromosome XP11.2 locus, specifically at that locus. So whatever, and there are other abnormalities which are causing the overexpression of this TFE3. The neoplastic cells have clear cytoplasm and the papillary architecture. It's as if it's combining two of our RCCs. Collecting duct or belly duct carcinoma, 1% or less of the renal neoplasm, that means it is rare, very rare. Collecting duct cell in the medulla, that is the origin. Many losses and deletions, but there is no specification like, for example, RCC, clear cell RCC and papillary RCC, we have a specific entity, that is specific gene locus that we know this chromosome is mutated in VHL gene, chromosome 3 is mutated in clear cell RCC. In papillary we know meta-oncogene, which is 7, trisomy 7, we know that, but specific pattern is not seen. So these are cells which form glands. These are the cells of the neoplastic cells of this tumor, they form glands. These glands are embedded within a stroma which is fibrotic, and typically in the medulla, collecting duct cell in the medulla. Medullary carcinoma is a morphologically similar neoplasm, but that is more common in patients with sickle cell trait. I think this was the last slide. Yeah, I hope you understood RCC. It was, I understand that for you guys it is a little difficult topic, but just the syndromic associations, and remember the syndromic associations, these, and of course if you don't remember this also, just remember this, that for clear cell we have VHL chromosome 3, and for papillary we have trisomy 7 met-oncogene, proto-oncogene, and both of them, both clear cell and papillary, have both familial and sporadic forms. And then we have the classic triad. No matter what RCC it is hematuria, abdominal mass and flank pain, and paraneoplastic syndromes, the classification. I hope you are able to understand this topic much better now. I'm going to upload more about renal diseases later on.